Welcome. Thank you for attending Early Orthodontic Treatment. My name is Tracy Wazinski, Business Development Coordinator at OfficeSite, and this educational webinar is made possible by Dr. Rondo and Lee Larstone, who have done a great job putting this presentation together, and OfficeSite is the proud sponsor. Having built over 7,000 websites, OfficeSite is the official website provider for healthcare organizations, and we are dedicated to providing you with the educational and tools needed for a successful practice. Our goal today is to educate you on some key components to help you succeed and understand the importance of early orthodontic treatment. First, a few quick housekeeping items, however. This webinar does qualify you for PACE-approved credit, so that's 1 credit, and Lee Larstone runs point on that. So she'll be available for any questions on the CE credit, and we will be providing you with a link for a test at the end that you'll need to take and submit for that. We also plan to run some polls throughout the webinar, so keep an eye out for those, and please be sure to participate to get the most value from the session. Now, for audio and listening pleasure, we do recommend dialing in on a landline phone if possible. If not, it's not a problem listening in on your laptop or cell phone or anything. We just tend to find that the best connection is with a landline phone. If you are finding yourself having any technical issues, please reach out to the GoToWebinar support for any troubleshooting. And then if you take a look at your control panel, you'll see a questions tab. You can please go ahead and type your questions in there as they come to mind. We'll get to as many questions as we can at the end with our live Q&A session. Lastly, there will be a quick survey at the end to get your feedback. So if you could take a quick minute and answer about 5 questions, we'd really love to hear your thoughts on today's session. So with that said, I'm going to go ahead and introduce you to the man of the hour. Dr. Rondo has been teaching for over 35 years, having instructed over 20,000 dentists in 7 countries, and is a diplomat of 5 highly respected orthodontic organizations, including International Board of Orthodontics. He is also a general dentist with 50 years in practice, and he also lectures 100 days of the year. Combine that with his 10 days a month that he practices, it's easy to see that Dr. Rondo is not only very knowledgeable, but also loves to help dentists in general and with their practices. So it's a real treat to have him here this afternoon. I'm going to go ahead and turn this over to Dr. Rondo so you can take it away.
Thank you very much, Tracy. Appreciate it, and welcome everybody. I hope that you're interested in treating some of the children in your practice, because more and more orthodontists are starting to treat children, and but GPs are doing it big time, and general dentists are finding that they want to help treat the children and do the easy cases. So I'm going to show you some simple cases today that I think you can treat. And we still recommend you send the difficult cases to the orthodontist. That's Dr. Kent Lawson, an orthodontist friend of mine who wrote a great book. It's called Straight Talk About Crooked Teeth. I would recommend that you look that up on Amazon and order that book. I actually give it to all my patients who come in, because it's exactly the treatment philosophy that I have, that he uses also in his practice. So it's treating early with functional appliances to solve problems early before the permanent teeth erupt. Now here's the deal, 70% of children have a malocclusion. That's a huge number of patients in your practice that could have help by you if you took a basic course in ortho. Now I do have a basic 8-day course on introduction to orthodontics, and we teach functional appliances and we teach straight wire. And I treated this patient with a functional appliance. So functional appliance is an appliance that advances the mandible without surgery. And you can see that's a huge difference in her profile. And that was wearing a functional appliance for probably 9 months. And I'll show you a few of those before the course is over. Again, age 7 is a good time to start. And try to treat the children early. It's less expensive and it's easier for them to cooperate when they're 7, 8, or 9, rather than when they're teenagers. That's another patient I treated. She had a retrognathic, underdeveloped lower jaw, and brought her jaw forward. I did that case about 25 years ago, but what a difference in her profile. There's another one. So if you've got children in your practice, when you have them up sideways biting on their back teeth, have them move their lower jaw forward end to end and have a look at the profile. And if it improves, then they need a functional appliance to move their lower jaw forward. Also, have a look at the arches. And if you see a constricted, narrow, V-shaped arch like you see in the top photo, you want to put an expansion appliance in there and widen the arch out. When you do that, you also help the patient to breathe through their nose, and there's more room in their mouth for their tongue, so they speak better, and also they have a broad smile. And you don't have to extract teeth. Mothers and children do not want extractions. They do not want surgery. So in North America, in my opinion, based on talking to all the dentists who have taken my courses over the last 35 years, the majority of orthodontists are into fixed braces, permanent dentition. And I'm not saying there's anything wrong with that. It's just that I think that in South America, well, actually in North America, and then there's a high percentage of extractions still going on, but it's less and less every year. More and more orthodontists are trying to do less and less extractions. But in my opinion, it can't be done easily with just braces. You really need to use functional appliances to develop the arches and then the braces. So in Europe and South America, crooked teeth are treated with functional appliances. They develop the arches and they do non-extraction. So it's a different philosophy. So you can look at smiles and of course look at the one on the left and she's got a beautiful broad smile, and the one on the right, you can see it looks like he's got black corners at the side of his mouth. And so I like her smile a lot better than his. And I think if I saw a patient like on the right, I would put an appliance in and develop the arch. And of course it looks like she got a beautiful arch. I'm not sure if that was natural or whether that's her arch, but she got a beautiful smile. And here's a patient I treated. I think you'll agree. The narrow smile on the left compared to the broad smile on the right. And I expanded her 10 millimeters. So I put a fixed appliance in and developed her 10 millimeters, and her smile is gorgeous. Here's the first patient, little guy, 6 years old, and it's very simple. All the GPs listening on should think, very simple rule. If there's no room for the permanent central and lateral incisors, you need to expand. That's it, okay? So he's got no room in the upper or the lower for the permanent central and lateral incisors. So we need to expand the arch. If you don't expand the arch, many times the lateral will come in on the lingual, and maybe the cuspid will come in the labial, and that's not good. So why don't go in there when he's 6 years old, good cooperator, put a little appliance in with a couple of clasps on each side, one screw in the middle. You turn the screw twice a week. Each month it opens 2 millimeters. So if it's open 6 millimeters, that'd be about 3 months. Wears it all the time. Takes it out for sports, active sports, to clean it, and just turn the screw 1/4 millimeter every Wednesday and Saturday. And it comes in different colors. So the kids really like the fact they can pick a different color. It's fun for them. And there's the key that comes with it to adjust the appliance, to take it out of the mouth, turn the key, put it back in. I mean, it's pretty simple. And look at the difference in the arch. And that was just an upper appliance, maybe open 6 or 7 millimeters. And you can see now in the upper photo, there's no room for the permanent lateral incisors. In the lower photo, you can see they're in. And he actually never came back for braces. So maybe because I expanded his upper arch and his lower arch, he had room for all his permanent teeth. He never needed braces. Wouldn't it be nice to fix him from, say, 6 to 7? And that's all you have to do. There's the lower arch, and he had no room for his lateral incisor. You can see they're coming in sideways. Or primary laterals are sideways. So again, we used a lower Schwartz appliance on him. And we opened the screws 4 millimeters, and you can see a big difference. There's going to be room for those teeth. Pretty soon there'll be room for all those teeth. There they are. So look at the difference in the upper photo and the lower photo. Now you can see there's more room for teeth, but more room for his tongue too. He can speak better. So it's just, there's no reason not to do this on our younger patients, rather than wait until the lateral incisors are up on the lingual. It just doesn't make any sense not to put these appliances in. So it improves nasal breathing, more room for the permanent teeth, broad arch, easier to speak, beautiful smile. I mean, those are the advantages. And they pay you. I mean, they pay me, the mothers pay you well for this, because the mothers all want their children's cases treated early. They don't want to wait until there's a major problem. So you can see, it looks, he's probably 8 or 9 now, and you can see his teeth came in beautifully, and in fact, he never came back for braces, so maybe all the rest of the permanent teeth are erupted. So he might have had a little bit of a deep overbite here, which maybe we could have fixed, but the mother was happy with that final result. Now, he didn't come back to me, so I assume that he looks pretty good. So this is that last year, actually, and I should get an up-to-date photo on that, but March of last year, we had 60 new patients, 33 ortho, 17 TMD, and 10 sleep. And OfficeSite helped me get a lot of those patients. In fact, maybe all of those patients. I mean, the websites that you do for us, Tracy, are phenomenal. I've had you working with me for 12 years, and I know you've been coming to my courses for 12 years, and I can honestly say I've had one dentist that went with you in the last 12 years on my recommendation that ever said they regretted it. They're all really pleased with your service because you're constantly upgrading. You're constantly adding new things to the website and giving us more new information. So that patient paid $2,000. That's an upper and lower Schwartz appliance, very little time on my behalf. The patient did all the work, they turned the screws. So the patients pay you well for phase one. So there's a nice view of Hawaii. Here's another little guy. Now this guy's 5. So the other guy was 6, and here's a guy that's 5, and he was a poor cooperator. Because some of you are saying, well, what if they don't wear the appliance? Well, he's got a constricted arch. Again, no room for his laterals. So we're going to go with a fixed appliance for him. So there's the fixed appliance called the transverse appliance. And in the course, of course, I give you a lot more details, but it's just 2 bands on the molars. And that's a nickel titanium coil spring at the front, which automatically expands. You just put it in and it works by itself. No screws to turn or anything. When you put it in, you measure that part that's measured 4 millimeters. And you measure that in the beginning when you put it in. And then you can see from the photo in the lower that expanded 8 millimeters. So we got an increase of 4 millimeter expansion. And that probably was about 1 millimeter a month. And it doesn't, and we did the top first because it's only 5. So we put the top in first, expanded for 3 months or so, and then we'll put the lower one in. So the upper arch expanded nicely. You can see the buccal crossbite on the bottom. And it's painless. It goes so gradually, there's no discomfort. The patients love this appliance. And the mothers love it because there's nothing to do. So there we put it in on the lower, and we measure that little area, 6 millimeters, because that's the part that increases. And so now he's got upper and lower, transverse. And see, upper and lower arch expanded. Look at the difference now. There's room for the 2 central incisors on the bottom. And hopefully there's room for the lateral incisors. And look at the lower. Look at the upper photo, how narrow it was with the 2 central incisors crowded and the laterals no room. And now in the lower, you got 4 teeth. So it really does make a difference. Now it looks like there's a little redness on the lower photo where it came out, but that'll heal up very quickly in about 3 days with salt and water rinses. But what a difference in the size of the arch. And again, it's so simple. The appliances work by themselves. It's a self-activating nickel titanium coil spring. So again, that's the last photo I had. We moved away, but you can see that in the upper photo, there's no room for the centrals or laterals. In the lower photo, the centrals are in much larger than the primary centrals, and there's room for the laterals. So easy. Mothers love this treatment. And again, they pay you for this. So we started out with 4 millimeters when we started the upper appliance, you can see, and down below, it's open to 10 millimeters. So that expanded 6 millimeters and made room for those teeth. And again, the mother will pay you for this. They love it. And there's not much to do. The patient just comes in every month and we just make sure that the bands aren't loose and everything's fine, and we measure the opening and off he goes. So again, that's so much different. And mothers would much rather have their children treated early than wait and deal with them when they're teenagers and try to get them to do what they're supposed to do. So that's Rondo Seminars number, www.rondoseminars.com. And you can call Lee at rondoseminars.com and we can get certificates for you. So at the end of the course, I think there's 5 or 6 questions to answer, and we give you a 1-hour CE credit. So if you want any information on the course, look at the website and you'll see my course brochures and all my courses on the website, and love to have you sign up for some courses. But even if you don't, I'm happy that you got some information today that's useful. Well, I went to Turkey and had a course, I think about 4 years ago, and they get a certificate from the International Association for Orthodontics. So that's an organization that I support. I'm one of their instructors, and everyone that takes the course, we recommend you join that organization. It's about 3,000 members worldwide, and that's an organization that helps you when you want to incorporate ortho into your practice. So here's the most exciting guy I've ever seen in my life to get a certificate. He just thinks he won the lottery or something. Anyway, he's very excited. So So it's important to join an organization if you're going to do orthodontics. Now, what's polling question number 1?
Yes, Dr. Rondo, the first poll question, this one's going to have to do with office site. I did first want to preface the poll question with, a thank you, first of all. I know you had some kind words for us earlier in the presentation, and we really love to hear the great feedback. And, you really speak to our mission at Office Site. We really want to help all dentists succeed with an effective online presence. And so I really quick just wanted to tell you about the type of program that Dr. Rondo is set up with, and then get you back to the presentation, because the whole reason Office Site is around is to help dentists succeed. So we do have a simple platform and make everything dentist friendly. We also help to manage your SEO, your online reputation reviews, your social media. We include patient education, all while leveraging the latest trends. So we really cover basically anything you would need in terms of, an online practice and succeeding with marketing your practice online and drawing patients in that way. With that said, I want to respectfully and professionally follow up with anybody who's interested in their own website evaluation. So I'm going to go ahead and launch this poll. If you can go ahead and let us know if you are interested, like I said, in a free online effectiveness evaluation. Once you've taken that poll, we'll go ahead and get back to Dr. Rondo. So let's just give this a second here to finish up with any votes that we have. Looks like we got about, most of the people voted. Give it a couple more seconds. So yeah, this is great. It's free. It'll help you to see where your website's currently at, where you can use improvements, anything like that. So I'm going to go ahead and close this. And we'll get back to the presentation. Again, I wanted to say thank you for the kind words, Dr. Rondo, and thank you all for attending this afternoon. And I'm going to go ahead and turn it back over to you.
Well, one thing that you taught me was if we get a negative response on the website, to respond to it right away. And frequently, when I get a negative one, the patient doesn't sign their name. And so, so we say to the patient, we respond on your recommendation that please let us know who you are so I can respond to the problem that you have and I'll fix it. And by doing that, you nullify the negative response or negative comment. And so you've been a big help to us. I think we've now got you've got it set up now directly with Google. And there's a button right on our website that when a patient says something nice about us, we hand them the computer, and they fill it out right then and there, and it goes right to the website. And I think you look at it first and make sure it's okay, and then it goes up. Or maybe that's our Facebook. I can't remember. Anyway, the girls handle all this, but I can tell you
that's great.
Whatever you're doing and they're doing is working, because we're getting a lot of new patients. I had 8 new patients yesterday. Now, we don't always get 8, but we had 8 new patients yesterday, and they're coming from, many are coming from the website. I mean, and so, I mean, you're a big help, and your SEO campaign is so valuable. I give you, I know, $300 a month, and when that used up, then it goes on the next month. But it's a budget we're following, and it's certainly well worth the money we're spending. So again, okay, let's go. So, there's my level 1 course starting in Chicago if you're interested, and it's in 5 other cities. Okay, let me show you this now. So in comes this little girl, very pretty little girl with an anterior crossbite. Okay, there she is. So when she smiles, not a very nice smile, and the mother wants that fixed. And the mother can't understand why you would not fix that, why you can't fix that at age 8. Why do you have to wait till 13 to get it fixed? And it's affecting her smile, it's affecting her self-esteem, and the mother wants it fixed. So we put an appliance in. So we have to open the bite, right? You got a deep over bite. You can't move that front tooth forward, excuse me, unless you open the bite. So we put plastic over the back teeth to open the bite. And you got 4 clasps, 2 on each side. The posterior pads are about 2 millimeters thick, so they won't break. And you got 1 screw, just 1 little screw. You just turn the screw, and the central incisor goes labially. That's pretty easy. Okay, so there it goes. The anterior screw, you open 4 millimeters, and the tooth's out of crossbite. And so that took 2 months. 2 months to get that tooth out of crossbite. So there you can see. Now this is a few months later actually, because you can see the healing that took place. Look at the upper photo. It looks like someone took a hammer and hammered the bone there. It looks terrible due to traumatic occlusion. And the lower photo looks fantastic. I mean, look at that tooth. It came in beautifully. And that was so easy. And that crossbite was fixed in like 2 months. And then we let it heal for a bit, and then I took a photo, and it looks great. So there it was. I mean, it's not difficult. The patient puts the appliance in, she turns the screw twice a week. It opens 2 millimeters a month. We opened it for 4 millimeters and fixed it. And so very, very easy, and what a difference. The mother was so happy. Look at the different smile. So the smile on the left is actually weak, right? And she's kind of self-conscious about her front teeth. And then she feels much better about a smile on the right-hand side. And so I charged her $2,000 for that. The ortho fee was $1,500, and the records were $500, and the mother happily paid me $2,000. She was very, very happy and thought it was well worth it. Then she comes back at age 12. She goes back at age 12 because she's happy what I did with her, and you can see the photo on the up above. That's what she looks like at age 12. And then we put braces on her for 1 year. We straighten her teeth. Okay, and there you can see the final result. Looks pretty good. So she got a beautiful finished result. And we put a lingual bond retainer on. Put that wire on and bond it to the lingual of the teeth so you won't get a relapse. Okay? And so there's the crossbite, and there's the crossbite corrected. And there's the winning smile. Look at the difference. Okay, so she started out with me at age 8. It took me maybe 6 months of treatment by the time I corrected the tooth and then brought her in for checkups. And then she came back to me at age 12. Now, my philosophy is I will subtract what they paid for phase 1 off the fee for ortho. So my ortho fee is $6,500. I gave her a credit of $1,500 because the records are different. And so she paid me $5,000 for phase 2, 12 months. So she had the brace on for 12 months. And those of you who are doing general dentistry know you work pretty hard for $5,000. And I worked fairly easily. We put the brackets on and changed 3 wires, and her teeth were beautiful in 12 months. So ortho can be very cost effective. You can do quite well financially, but you're going to have a lot of fun helping these kids, believe me. The children in your practice. Polling question number 2, Tracy.
Yes, so the next poll question we have is, so you must expand the arch when there is no room for laterals. Is that true or false? So give people a couple seconds to answer the poll question here.
If I get this wrong, I may have to retire from teaching.
All right, I'm going to go ahead and close it and share the results. So it looks like everyone's got true here.
That's fantastic. Great. I don't have to retire. Thank you, everybody. Okay. Okay, let me show you now a little 5-year-old. See, look at the young patient I'm showing you. They're all really young. And so here's a guy 5 years old, and this is an old case. You can see the photography is not very good. That's not a digital camera, but look, he's got an open bite of 7 millimeters. That's because he's got an anterior tongue thrust. So he's putting his tongue between his teeth 2,000 times a day, and he's got this open bite. So I made him a tongue crib, made him a fixed appliance with a tongue crib, put the crib in there, and it looks like quite a device. It's got an expansion appliance in it, and it's got a crib at the front, and that prevents the tongue from going between the teeth. And you got a 7 millimeter open bite when we started, and at age 8 or 7, it's closed down almost all the way. And I don't think he's got an active tongue thrust, although it looks like there's still a little bit of an open bite. But that's what happens. So at age 5, he starts on the left, age 8. So the appliance is actually in for a year, and then we take it out, and then just let all the teeth erupt. So he came back at age 8, and that's what he looked like. And then I charged him $1,500 and $450 for the records, which is $1,950. And pretty easy. I didn't do anything, right? I just put the appliance in, and he turned the screws. The mother turned the screws to expand the arch, and then we took the crib off. So he had an open bite of 7, and at age 12 he comes back. He looks pretty good. So at age 12, he comes back and asks the mother if he needed braces. And I said, he looks pretty good. But if you want, he was coming from out of town. I could put brace on for a short period of time. But the mother said, the bite's pretty good. His teeth are straight. I'm pretty happy. So he never had phase 2. He could have had phase 2 to be slightly better. But boy, that one appliance did a fantastic job. So they paid $2,000 instead of $6,500. He looks pretty darn good. So there he is. Happy guy, no braces. So I treat him at age 5 with a fee of $19.50. Doesn't need phase 2, didn't need braces. Pretty nice results. And that's what you want to do for your patients. If you treat early, sometimes they don't need braces, or you can minimize the cost of the braces. So we have a big meeting. For those of you who may be advanced on the call tonight, we have a big meeting, an orthodontic case finishing conference at the Paris Hotel in Vegas. We usually get about 125 dentists, October 20th, 21st. So I'm speaking about case finishing in class 3 malocclusions. I've got another orthodontist, periodontist. He's a specialist in both areas, and he's talking about accelerated orthodontics, how to make the teeth move very fast. Using Propel. I don't know if you're familiar with that technique where you make actually little holes in the gingiva into the bone and speeds up the eruption and the movement of the teeth. Here's Dr. Palangar, who's going to be teaching also on case finishing. Now here's the real star of the show. This is Dr. Carrier, who's an orthodontist from Spain. And he's developed a new appliance called the motion appliance, which I'm so enthusiastic about. And he's going to be talking about, I'm going to show you one case. He's talking about class 2 and class 3 corrections, okay? And it's amazing. So here's the Carrier motion appliance for class 2s, okay? So you put a lingual arch on the lower, or you put an S6 retainer. You have to do something to hold all the lower teeth together. And you can see this one has an S6 retainer. So if you have an S6 retainer, you can see there's a bracket on the lower second molar. And all it is a bar. You can see in the right-hand photo, it's a bar that goes from the cuspid to the molar. They come in different lengths. And you glue that right on the teeth. And the patient wears those class 2 elastics. And the whole lower arch skids forward and corrects your class 2. So those of you who may be familiar with this, highly recommend you come to Vegas because Dr. Carrier is going to show many, many cases. And I also teach this in my course. And he's going to speak for 4 hours in Vegas, showing all class 2s and class 3s. So you also come in clear. And I'm not going to show you those today, but the bar comes in clear also, as well as different colors for children. So here's a case. The patient is a little bit challenged, mentally challenged. And so she's 12 years old. And she's got a little bit of a retrognathic mandible. And she's got an overjet of 6, and she's biting on the roof of her mouth. Okay, so you can see she needs to have her lower jaw move forward. And she's biting right on the roof of her mouth. Okay, so she needs treatment. Okay, so she's got a class 2 cuspid and a class 2 molar. So we have to bring the lower jaw forward. We've always got 2 choices, right? You can distalize the upper, or you can bring the lower jaw forward. This Carrier appliance, I think, may distalize slightly on the upper, but mostly the lower comes forward. And for those of you who do TMJ, I've also done tomogram x-rays and joint vibration analysis to make sure that there's no damage done to the condyles of the TMJ and everything's favorable. So you start out actually with 6-ounce elastics for the first month, and then you go to 8-ounce elastics. So it's a pretty big elastic. And there you can see the elastics are on there, and I put brackets just on the front teeth to straighten the front teeth lower. And you can see it's a pretty simple appliance. You got brace in the front teeth, and you've got this motion appliance going from the cuspid to the molar on both sides, and you hook the elastic up in the cuspid area. And there you can see that's prior to treatment. And there's the motion appliance. And you can see it's pretty easy to wear. I mean, all she does is hook up her class 2 elastics and wears that all day long. And we recommend changing them after every meal. And then a lower lingual arch. You have to make sure there's lots of anchorage in the lower. You're basically pitting the lower arch against the cuspids and the bicuspids. Okay, so there you've got the lower lingual arch, and I put flowable composite on mesial rest on the bicuspids. And there you can see. So you can see on the upper photo, it's got a class 2 cuspid, and down below, it's got a class 1 cuspid. Okay? So there she is with an overjet of 6, and now she's got an overjet of 2. Now the most amazing part of this photo is I've also corrected the deep overbite. Okay? So the deep overbite's corrected, and the overjet is 80% corrected. And now there's a space between the cuspid and the lateral. So now all we have to do is hold things back and move those centrals and laterals back the last 2 millimeters. So it really is a phenomenal appliance. And I've just been using it for the last 6 months or so, but I'm very, very keen on it. Here's another orthodontist speaking. So again, there's 3 orthodontists speaking in Vegas. And I think it's good for all general dentists to hear as many good orthodontists as they can speak about something new. And he's also talking about the motion appliance. He's also talking about accelerated orthodontics, when he's using Propel to make little holes in the bone to speed up the eruption of the teeth and get rid of bad rotations. So it's a new strategy. I always like to bring new things to Vegas. I actually haven't done it myself yet, but I had a talk with Dr. Shipley and Dr. Murphy, and they both used it for years, and I'm anxious to have them show their cases in Las Vegas. And we also have someone in practice management. Here's someone I've been working with for years at Strain Consulting, and Randy Bird is going to talk about how to increase the size of your practice. And that's Vegas. You can see we have workshops afterwards, and people are around. I'm doing bite registrations there on the right, and we're doing wire bending there on the left. So we have that happening right after the course is over. So some of the dentists stay from 5 till 8, 3 hours, just learning to bend wires, how to take impressions, all kinds of things we have happening in the learning lounge. And of course, there are drinks provided and food. So in my opinion, even though more and more orthodontists are doing it, most orthodontists are not treating children with mixed dentition. So therefore, I think it's an excellent opportunity for general dentists to help treat these patients, increase their income as a result, and also, I might say, increase their personal satisfaction from their practice. I love helping the kids. I love it when the mothers say, thank you so much for improving her smile, improving her bite, getting rid of her headaches, shortening her time in braces. Ideally, I'd like to finish the children at the end of grade 8. So when they go to high school, they don't have braces. And that's our objective. And here's another case with the tongue thrust. Okay, remember I showed you the last case. It had a rake at the front. Well, here's a case where I used a different appliance on him. At this anterior open bite, he was a hockey player and couldn't wear that crib because he had to wear a mouth guard. So I used what is known as MyoBrace. It used to be called Trainer. It's actually been around for 26 years. Came out of Australia. It's now called MyoBrace. And you can look it on the website, and it's phenomenal information on there. And so look on the website and find that. And there's all kinds of articles on there to prove why it works. And there's things for parents to read, and there's things for children to watch. It's very, very good. It's just a simple little appliance. And the tongue tab is up, and this retrains the tongue. So when you put that in, there's no way the patient can thrust their tongue through that. So there's the tongue thrust. There's the MyoBrace. Okay, it covers the upper and lower teeth, and you actually have 3. You have three different types. And I'm not going to go into the types right now, but we do teach this in our course. And it's worn a minimum of 1 hour during the day and worn every night. And you have to instruct the patient on some various exercises, how to breathe through their nose, how to use their diaphragm, lots of different things, but it's phenomenal. And the mothers love it. And there he is. 2 years later, it's closed down. Okay? Completely closed down 2 years later. Maybe it's even 1 year later, because he's just got his first bicuspids in. But that's quite a change. And look how the bite closed, just by wearing that appliance for probably 6 months and then taking it out. So look up myoresearch.com. That's the website, and watch the videos. It's really phenomenal. It's really, again, I've started using these I used that on him many years ago, and then stopped using them. And now I'm back using them because the children love it. It's a lot nicer than that crib. So that's the difference. So 2 years later, the bites closed beautifully. He didn't come back for 2 years. He lives about 3 hours away. And so I put the appliance in and said, good luck, just wear it. Now it's a little more sophisticated. We spend more time with the parents, more time with the children, show them some exercises, and do a lot to motivate. But I guess he was well motivated. He looks fantastic. And that's the difference. I mean, that's huge. And that is really a neat little appliance. And again, we charge about $1,500 for that too. So if I use a crib, I charge $1,500. If I use the mile brace, I use $1,500 because you need 3 appliances, and the appliances are worth about $75 each. So my lab costs aren't very much, and it works beautifully, as you can see from the lower photo. And you might be curious to see what he looks like when he's older. And so he came back when he was 16, and there he is. His bite's still closed, but he has some crooked teeth, thankfully, and now he's got him in braces. So I closed the bite down, but now he's got braces on, and we're gonna straighten his teeth. So here's a guy that comes in. Now again, most of us are not trained in TMD at all in dental school, and yet many of our younger patients have headaches. And many times the headaches are due to the mandible being in the wrong position and brought on by a deep overbite or a retrognathic mandible. So he's got a deep overbite and a retrognathic mandible, okay? So it's important that we bring his jaw forward, okay, and open the bite. So this is another appliance you may not be familiar with. It's called a Rickonator, which is like an anterior bite plate with a ramp. And he bites into that ramp, and that keeps his jaw forward. And then we do composite buildups on the primary molars. And then you'll notice the first permanent molars will passively erupt. So there he is. He can bite on those teeth now. We've established a new occlusal plane. We've corrected the overjet and the overbite and done the buildups. And that's all we do. And just wait till all the permanent teeth are up now. So that lower molar will come up. And you can see he had an overjet of 4, and now he's got an overjet of 1. An overbite of about 6, and now he's an overbite of 1. It looks a lot better. So we're correcting the skeletal problem and the headache problem and the overjet problem and the overbite problem with one appliance called a Rickonator and 4 composite buildups. And there he is that's just after, it's an hour later. His eyes look different. His eyes look different. And his profile looks different. Wow, what a difference. He looks about 2 years older on the right than he did on the left. He's only an hour older. But you can see his face looks a lot better. His face looks more in proportion. On the left-hand photo, he looks like he's overclosed vertically, and he is. Got deep overbite. Retrognathic profile. On the right, he's got a straight profile. So this is really easy. And then we did braces on him and straightened his teeth. So, you know, it was just, the mothers always, if you do a good job in phase 1, and you give them a discount towards braces, they'll always come back for braces. So let's look at some class 2s. Okay, so basically class 2s are you can wait and do braces in permanent dentition, maybe take out some teeth, if you take out teeth, you end up with a narrow jaw and a thin upper lip and constricted arches. If you use functional appliances, you do mixed dentition, you do non-extraction, you bring the lower jaw forward, you have a full upper lip, wide arches, broad smile, and healthy TMJ. That's, I think, what you want. The trouble is, a lot of malocclusions are class 2, so you really have to think about doing class 2. So here's a patient with a class 2 skeletal malocclusion. Okay. Remember, you got 2 choices. You can either take the top and move it back, or you can move the lower jaw forward. Well, I think the determining factor is, number 1, do they have jaw problems? TMJ, headaches, neck aches, back aches. If that happens, you got to bring the jaw forward. And number 2, what's the profile look like? If the mandible is retrognathic, underdeveloped, you got to bring the lower jaw forward. So, in 80% of the cases, the maxilla is normal and the mandible is underdeveloped. Okay? So, just bring the jaw forward and see what she looks like. And you can see the patient on the right looks a lot better than the patient on the left. The patient on the left had a lower jaw, which was retrusive. I always tell people, don't focus on the economy, focus on your economy. What's your economy? Your economy is how much you can produce in a day and enjoy your life. And so I think if you incorporate ortho into your practice, I've received all kinds of letters and all kinds of comments over the years, how dentists have thanked me for introducing them to orthodontics, and now they're doing their younger patients And even they're teenagers and adults now with straight wire, but just loving it. Particularly if you're in a state where your staff can do some of the work. And lots of the states, the staff can do some of the things and the dentist has to do some, but you can really utilize your staff to help you. And of course, we train the staff also with the dentist at the courses. So I guess, yeah, offer early orthodontic treatment and you're concentrating your economy. Now remember, build your practice. You have to be unique. Every practice management consultant tells you, you have to be unique. Do you like implants? Do you like cosmetic dentistry? Do you like ortho? What do you like doing the best? Well, then you should do what you do the best. But if you can offer non-extraction treatment and non-surgical treatment, you are going to find that your practice is going to be very busy. I told you I had 8 new patients yesterday. Here's a patient that was referred to a psychiatrist by the medical doctor because she had headaches. Well, she had a lower jaw that needed to come forward. And as soon as I brought her lower jaw forward, headaches went away. The headaches are eliminated with a twin block. I showed you that before. And there's another case before and after you can see. Here's another little guy. Now, how would he have gone out his whole life looking like the guy on the left? When I put a twin block in him and moved his jaw forward, I'll show you the twin block in a minute. And that's the Rickinator case I just showed you. And that's another little girl. I moved her jaw forward with the functional appliance. I mean, you need to diagnose the case. If you're not doing ortho right now, you've got 2 choices, in my opinion. Find an orthodontist that does functional appliances, that treats early, and send the case to him. Or if you don't want to send him several $100,000 worth of case a year, take a course and do the case yourself. Send him the difficult cases. You do the easy cases. So that's the course too. You can, again, we're in Toronto, Chicago, Calgary, Dallas, Las Vegas, Atlanta next year. So love to have you join the course. So here's a little girl, 8 years old, headaches. So what are you going to do if she walks into your office? This little girl walks into your office, your general practice, and she's got a headache. First of all, would you even ask about headaches? Do you think the mother would tell you about headaches? Mothers aren't going to tell you that the little girl has headaches. They're coming to you to get their gums and their teeth fixed. Okay, but she's got an overjet of 6 and biting on the roof of her mouth. And she's got a retrognathic profile. Her lower jaw's back. Clearly it has to come forward. And we have her fill out a form and she says, Mother brought Alicia home from school due to headaches. This little girl's being daily headaches, 8 years old. How would you feel if that was your daughter? Who's going to fix her? Who can fix her? Can a medical doctor fix her? He couldn't fix her. Can a chiropractor do it? Acupuncturist? No, you got to go to a dentist that uses functional appliances. That's it. That's your choice. A dentist or an orthodontist that does functionals is where you got to go. Okay. Got a class 2 molar relationship. Writing on the roof of her mouth. There's a form too. If you want to phone Lee at rondoseminars.com, we'd be happy to email this to you. And I would highly recommend you use this in your practice. Give it to every single patient. Look at her. You get headaches? Yes. You get migraines? Yes. Upper right. Do you get headaches to right and left temple area? Yes. Headaches in the front or back of your head? Yes. This poor little girl is getting headaches every day. Every day. And the medical doctor recommended adult migraine medication. That's not a good solution. Here's the solution. Here's the solution. See, she's biting on the roof of her mouth. Bring her jaw forward. Put her in a twin block. Twin block was developed by an orthodontist in Scotland, a friend of mine. Okay? William Clark. 40 years ago. 40 years ago this was developed. Okay? You wear this for 7 months and your jaw comes forward and stays there. 7 months. Okay? I charge $2,000 for that. See? Wanted to wear adult migraine medication. Sorry. MD wanted to put her on adult migraine medication. Okay, so here she is wearing a twin block. So it's 2 blocks to fit together. Now, the first time I saw this, I thought, wow, who's going to wear that? I can tell you they wear it. What's the alternative? The alternative is to wait until 17, have jaw surgery, and bring your jaw forward. Plus, research has shown if you do jaw surgery on a class 2 with jaw problems, you don't make it better. If you use a twin block or a Mara or a Herbst, you make it better. You have to move the lower jaw forward completely. You can't do surgery and fix the TMJ. Okay? 7 months. 2 blocks, interlocking at 70 degrees. You can see the lower block contacts the upper block at the back by the molars. She tries to move her lower jaw back. The lower block hits the upper block and she can't move. Okay, there's the twin block. I know it looks like a real bulky appliance, but I can tell you it works, gets rid of the headaches, they look better, and they wear it. Usually we have the midline screw and we have to expand the upper arch first. And there's the lower block. We have to make sure it doesn't touch the lower molars because we want the lower molars to passively erupt. So the lower molars come up, that fixes the deep overbite. They bite in front of the block for 7 months, that fixes the overjet. There she is. She wears 7 months and the upper teeth are erupting. Now she ends up with a little bit of a posterior open bite. So now the best thing to do would be to put composite buildups on the lower primary molars, like I showed you with the Ricinator, and hold the jaw forward. And then we have to go to a second appliance, which I'm not showing you, but we go to a Ricinator next. You did see the Ricinator. So she would then wear a Ricinator for 6 months. So twin block 7 months, Ricinator 6 months, headache's gone. Headache's gone. Okay? What's the alternative? Surgically advance the mandible at 17. And she'd have to go into braces from 17 to 19, which she should be going to university or college or getting a job. That's the improvement in her profile. She looks great. She looks fabulous. Her lower jaw is forward with no surgery. No extractions, no surgery. Wear the appliance for 6 months, 7 months. Look at the smile. Now, how do I feel about this? This little girl had major headaches every day, being home from school. Nobody knew how to fix her. I put in a twin block in a Ricinator, and now headache's gone. She looks fantastic. It looks like she's actually wearing her twin block in that picture on the right. But look at the difference in her face. I mean, don't tell me it's not a significant improvement in her health and her ability to cope with life. How would you like to have a headache every day of your life at 8 years old? It's not good for you. It's not good for going to school. It's not good for talking to your friends. Big difference. So you need to, all of you listening today, need to either find an orthodontist or a general dentist who take care of these patients, or you need to sign up for a course, mine or some other ones. But make sure if you sign up for another course, if it's not mine, that you ask them about functional appliances. Do they treat early? Do they concentrate on children, or do they treat mainly adults? Okay, the twin block did it. Okay, so I also have a website that helps you after the course is over. So you can join that website. There's over 750 cases posted on the website, and you can send me cases in the mail, and I will help you with the cases for a slight fee. And we also have articles and publications and discounts on courses, so it's a continuing thing. The other thing we're doing after the course is over, we're setting up study clubs and hands-on courses in offices all over the states. That's something we've just done in the last year. So again, we're trying to make sure that if you take the course, there's some follow-up, and we'll hold your hand and help you learn, you know, so that you can improve and help these patients, because it's a lot. If an orthodontist goes to school for 3 years now, it's a lot for general dentists to take any course for 8 days and get it all. So that's why my courses are on the internet. You can retake the course on the internet, the ortho course, the TMJ course, sleep courses, advanced courses. We're there to help you. And you have to consider it's going to take you 5 years to get good at this. Okay, so there's the courses that dentists submit to me, and along with the set measurements and everything else, and then I get back to them and tell them what I think. So again, call that number or go to rondoseminars.com. Talk to Lee. Lee knows everything. So talk to Lee at rondoseminars.com, and we'll help you with anything we can. One last case, okay? What are you going to do with this little girl walks into your practice? Are you going to send her to an orthodontist that doesn't do functionals? I hope not. Are you going to send her to a dentist that doesn't do functionals? I hope not. Make sure the dentist does functionals, because she needs a functional appliance. Look at her profile. So she needs 2 things. Her face is short, because she's biting on the roof of her mouth, you'll see in a minute, and she needs her lower jaw brought forward. There she is, right in the roof of her mouth, lower jaw forward. Overjet at 10. It's a big overjet, you know, but bring that jaw forward, she's going to look completely different. So, body in the roof of her mouth. So we started her with a banded Hyrex, okay? So we have to expand the upper arch. Remember I told you any class 2s need arch development first. So we expand her upper arch with a Hyrex. So the patient turns that screw, or the mother turns the screw twice a week, every Wednesday, every Saturday. And now the upper arch is expanded 6 millimeters. Now when you bring the lower jaw forward, she's not in buccal crossbite. Prior to that, when you brought the lower jaw forward 10 millimeters, she was in buccal crossbite, and you don't want that. Okay. Large overjet at 10. Patient's going to advance the mandible to an ideal overbite and see what she looks like. You do this before the treatment, but that's pre-treatment. You saw what she looks like. There you can see the difference. Okay, so the one on the left is her biting in centric occlusion on her back teeth. The one on the right, she's biting end to end. So we fix the deep overbite, we fix the overjet, and we want to see what the face looks like. Have the mother look at that face and ask her what face she likes the best. Take photos with your digital camera and show the patient both photos. And I can guarantee you, when you show that patient that photo on the right, she will wear whatever you put in her mouth, forever, whatever length of time you pick, because she wants to look prettier. And she doesn't want that buck teeth look anymore. She doesn't want the children making fun of her. So that's an appliance which looks like quite a contraption, I admit. When I first started to use these appliances, probably 15 years ago, and an orthodontist introduced me to this. A general dentist took my ortho course, went and became an orthodontist, came back and met with me in Calgary and brought this appliance to me and said, "You gave me quite a gift. You fired me up on functional appliances and early treatment, and I'm not sure if you've seen this appliance." And I said, "I have not, because it was developed by 2 orthodontists that he knew, and he brought this to me, and it's the Mara. I've been using it for 15 years. And it looks like quite a contraption, but believe me, it works." So there it is. So you can see the arm coming up from the lower stainless steel crown, and that holds the jaw forward. Because behind that, there's an elbow. So the patient tries to move their jaw back, the arm hits the elbow, and you can't move back. So there it is. There's the lower. I haven't got time to go into the details. I just want to show you how they work. And here's the patient wearing the Mara, and that's after several months. It takes us probably four months to bring the jaw completely forward. And there she is, and I had to do build-ups, a blue build-up on her lower molar so she could chew, because when you open the bite, you always have a posterior open bite. And then I put the braces on, and then I put the Rickonator in. So the Mara is in for 7 months, and the Rickonator goes in after the Mara or after the twin block for 6 months. Okay? So then we're erupting the teeth with elastics. You have to use a rectangular wire in the upper, and a round wire in the lower, because you want to bring the lower teeth up. Okay? You don't want the upper teeth to come down. You've got a deep curve of speed, and you want the lower teeth to come up. So he wears those elastics for several months, and you can see the deep overbite's been fixed. She's still got a Rickonator in there, which holds the bite open in the front. And there she is done. Okay, I think it's a pretty nice result. And it probably took me about maybe 2.5 years. 2.5 years with the Mara, with the Rickonator, and the braces. Okay, so you can see, and that's quite a change. And no surgery. No surgery. So you can see she's got an ideal overjet, ideal overbite. And she had a 10 millimeter overjet, and she's biting in the roof of her mouth, probably 8 millimeters. So that's quite a change. And she's pretty happy. And of course, the jaw is fixed too. When you bring the jaw forward, you fix the problem with the jaw. And then you put a lingual bonded retainer upper lower so that you can make sure that those teeth don't move. So that's on there for 10 years. I tell the patient will be on for 10 years. I'll be retired by then, so I won't, it doesn't matter. But sometimes we leave it on longer than 10 years. But I tell them 10 years. And that's a new retainer, which some of you may not have seen. You may be familiar with the Holly retainer. That's a QCM retainer with a clear labial bowl. And that's quite nice. So that goes right across those teeth. And really, when the patient wears that, you can't even see it. So there's the change in the profile. So that's a lot nicer than before. And the chin does continue to grow. So her chin, her pogonion did continue to grow, but she still looks so much better than she did in the beginning. And that is phenomenal, I think. I mean, look at the difference in the buck teeth on the left, and look at the difference in the beautiful smile on the right. But remember, I expand her like 6 or 7 millimeters with the Hyrex first, and then also with the Mara appliance, I'd be able to expand her because the Mara appliance also has a midline screw. And then 2 years later, she comes back and says, guess what, Dr. Rondo, I'm a model. I got some pictures to show you. I said, well, you might get your pants fixed for starters. But she said, no, that's the style. I said, you actually buy them like that? She said, we buy them like that. I said, that's amazing. And that's my favorite photo. That is such a different person, than the one that came to see me at 10 years old. She's 15 now. She's 15, she's a model, and she's got all kinds of confidence. Obviously, if you have a lot of confidence, you want to be a model. And just look at her, just the way she's standing and holding her head and showing off her new smile. So that's her at age 10. And the bottom picture is my favorite picture all time at age 15. Do you think I changed her personality? I changed her appearance, but I think when you change the appearance, you also change the personality. You gave her confidence enough to want to be a model, and she's just a sweetheart. I mean, she was a sweetheart at age 10 with the buck teeth and kids teasing her, and then at 15, a model. I mean, she just looks great. So that's why I think you should all think about either sending your patients to someone who does functional jaw orthopedics or take a course and do it yourself. I think my course is $4,000. One case pays for the whole course. Now, I realize you have to take time out of your office, and maybe you want to train your staff, and you might have to stay at a hotel. You can take the course online, though, and not have any of those costs. So the course online, and we have dentists starting the course just after taking the online course. You put brackets on typodonts, send us the pictures, we check it off. You trace 15 sets, you have to send them into us, you have to bend wires, you have to do a lot of things. I think it's easier myself to be at the course and have some people showing you hands-on, but people start cases just by watching the online course. So you can have a choice. So anyway, there she is showing off her new smile. And that's the internet course. So you guys should get a special if you sign up for the internet course, but really I'm really happy that you gave me the opportunity to talk to you today. I really do love to teach. I really hope that more dentists and more orthodontists will get into treating the children early in the mixed dentition and not wait until permanent dentition, because really it's so much easier and so much better to treat the functional problems in mixed dentition. The tongue thrust, the thumb sucking, the TMJ problems, and the skeletal problems, the narrow upper arches, the retrusive lower jaws, retrusive upper jaws. I haven't shown you any class 3s today, but we teach class 3s also in the course. I did show you one class 3 with a crossbite. But really, it's something I believe general dentists can do. I have thousands of general dentists who've taken my courses, and I think the biggest thing they tell me is, number one, they treated their kids properly. They were able to, when they've got young kids, young children, they were able to do the right treatment for their children and not wait until the child was older and run the risk of extraction or surgery. And also, it gave them a lot of personal satisfaction with their practice. So I think if you take the course, love to have you take it. And thanks for attending. I'm certainly open for some questions today. Oh, polling question number 3. What's polling question number 3?
Yeah, we can shoot that one off real quick and then get to the Q&A. So the third polling question is, a tongue thrust habit does not need to be corrected before you do any orthodontics. So kind of giving a couple seconds for people to go ahead and vote on that for their answer. And I'm going to go ahead and close it and share. It looks like we got 13% true and 88% false.
Okay, the 88% win. Yeah, you really do have to treat the function first. If the base of the tongue thrusting habit, you have to stop that, because if you put the braces on and use elastics to close the bite down, the tongue will beat the elastics and the bite will open up again. And it's really important to do it at a young age. It's really tough. In fact, many, many times when an adult comes to me, if they won't wear the myo brace, which is that rubber silicone appliance, I will not treat them many times, because it's very difficult to treat a tongue thrust with an adult. And many of them don't want to wear that crib. So many times I just say, if you won't wear the myo brace or the crib, I can't treat you. So that's why it's so easy. The children will do what they're told, right? I did what I was told. Tracy, you did what you're told when you were younger. Your mother told you to do something, you did it. Well, not so much as teenagers. Not so much as a teenager, but when I was younger, right, it was very clear, just do it. And that's why we really want the kids to be treated early. So the thrust today is on mixed dentition, and so I'm hoping that they got that message. So do we have any questions? Any questions?
Yeah.
Yeah.
Yeah, no, that's perfect. I know, some of you guys might have to get going, so we're about to start the Q&A, but I just did first want to thank everyone for joining us this afternoon, as well as a big thank you to Dr. Rondo and Lee Larston for putting this great presentation together. And then a quick mention, I had mentioned earlier, you can get your free evaluation of your web presence, and we'd love to help you with that. So you can reach out to me at T.Wazinski at OfficeSite. That's TWASINSKI@OfficeSite.com, and we can set up an appointment for you to get that taken a look at. And then I'm also going to go ahead and paste the link for the CE test in the chat box. So if you want to go ahead and take a look over there, you'll see the link to take the CE test. But again, don't take off. We do have some questions coming up, and I'll get started with that now. So the first question we have is, how early is too early to treat?
I think if you can take impressions on the patient, and they're good cooperators, and the mother is into it, I think I've started patients as early as 4. Probably my preference would be 6, because they're usually a little smarter at 6 and very cooperative at 6. And of course, your ideal patient is an 8-year-old girl. 8-year-old girls will do anything you tell them. They're so smart. But we have started at 4. And certainly functional problems, no braces at 4, just fix the skeletal problems, maybe put an appliance in to expand the arch. I showed you a 5-year-old when I use that transverse fixed appliance. If he'll let me take an impression and fit some bands on his teeth, we can do it. So, and the mothers want them treated early. I mean, they're bringing them in at 4 and 5 and 6. And if I've got a good attitude and a good mother and a good child, we can start them. Kids are smart these days. But you have to educate them. You have to explain why they have to wear it. That's why it's really important, I think, to train your staff. My staff play a huge role. I have 8 staff. I run 6 chairs, and we're busy. And my staff do a lot of the work, because I just go from room to room and tell them what to do. There's an orthodontist in Wisconsin. He doesn't like me to use his name, and he sees about 120 patients a day. And he does it all because they're all in functional appliances. All his kids are in functional appliances, and it just takes a minute or 2 to check them. So he's got this huge practice, 120 patients a day. I don't have quite that many. I probably see 50 or 60. But I mean, he's going gangbusters, and it's mostly all functional appliances. And it's amazing. He's spoken at my meeting in Vegas, and he's phenomenal. So you can really, it doesn't take a lot of time. You can be doing restorative dentistry in one room, and you can be doing some sports appliances and some functional appliances in the other room, and just go in and check on the child and say, you're doing a great job. We'll see you in a month. So earlier the better.
Awesome. The next question we have for you, Dr. Rondo, is how long is phase 1 treatment?
So phase 1 treatment is usually an appliance. That's a good question. So let's say the patient has a constricted upper arch, no room for the lateral incisor. I would put a Schwartz appliance in and expand it maybe 4 months. So I'd expand it 4 months, and then I would have the patient wear it another 6 months to hold. So it'll be 10 months. Okay, 4 months actively turning, 6 months in his retainer. But you don't have to see them every month if they're only coming in to get it checked as a retainer because you don't turn the screw anymore. Okay, so the average phase 1 for expansion would be 10 months. If you're doing a twin block, then that would be longer because you'd have to wear maybe an appliance first to expand the upper arch, maybe for 4 months, and then the twin block for 7 months, that's 11 months, and the Reckonator for 6 months, so that's 17 months. So if it's a class 2, it might be 17 months. But again, they don't have to come in every month. I mean, you know, every second month or so. You can just check to see if the appliance is working and not loose or anything. So it's very cost effective. But it's and so that's that. And if you're doing a tongue thrust problem, you would put the appliance in. You need 3 appliances, and that would be each appliance would be in for about 4 months. So if you use the myo brace, it'd be like 12 months. You wear each appliance for 4 months and 3 appliances. So it just depends on what you're doing in phase 1, how long it takes.
Great. The next question we have for you, Dr. Rondo, is when do you use a Mara versus a twin block?
That's a very good question. I didn't answer that when I gave the lecture. I remember the twin block is used for anybody under age 11. The Mara is used over age 11. The reason for that is when and I went over these things pretty quickly. When the elbow and the arm hit, you can cause root resorption. And so if you put that Mara in the beginning, when the patient's kind of trying to get used to where the elbow and the arm is, and there's some traumatic occlusion on the lower molar, if you don't have your roots formed all the way, you can cause some root resorption. So after age 11, the roots on the first molar are formed completely, and you can't cause any problems with the Mara. So under age 11, twin block, over age 11, Mara.
Perfect. And the last question looks like we have for today. If anybody has any last minute questions, go ahead and shoot them in. But otherwise, this will be some before we wrap up is when do you move to phase 2 of treatment?
Usually when all the permanent teeth are up. So phase 2 starts. Phase 2 is usually, phase 1 is using the functional appliances to expand the jaws, correct the deep overbite, the overjets, bring the jaws forward. And so then we wait until all the permanent teeth are up. And what I'd like to do is anybody who's class 2, fix it with the functional appliance and mixed dentition. And then when they get the braces, that's phase 2, and all the permanent teeth are erupted. And then many times you put the brace on for 1 year and you're done because you've done all the hard work in phase 1. You fixed all the overjet, the overbite, the TMJ problems, the crossbites, everything in phase 1 with the functional appliances. I mean, I couldn't practice without those. And the problem is, I mean, there are some orthodontists trained in ortho school to use them, but not a lot. It's not taught in a lot of ortho programs, and it's not taught in the majority of dental schools. It is, however, in South America and in Europe. So when I've lectured in Europe, they're right into it. They just want to see the new ones. And for those of you who have taken the course before, I showed 2 new things today. I showed that motion appliance, which is fantastic. And again, Dr. Kara is going to be speaking about that in October. If you're experienced, I wouldn't recommend the October course for beginners. I think you'd be blown away. But for advanced, anybody doing ortho, that October, my case finishing seminar would be great to attend. And the myo brace. Those are 2 things that are new that maybe some of you haven't seen before, because I've just started using both of them about 6 or 7 months ago. So I guess that's the last question.
Yeah, I was just going to say, that all sounds really great. That was all the questions we've had and the time that we have for today. So again, thank you, Dr. Rondo and Lee, for putting this on for us. Thank you for everyone for attending. As I mentioned, I did share the link for the CE test, and I will be including that in the follow-up email as well, so keep an eye out for that. And please reach out to myself or Lee if you guys have any questions after we wrap up for the day. So again, thank you very much, and thank you, Dr. Rondo.
One last thing, this is being posted on my website in the future, and there's a lot of other seminars or webinars that are posted on my website. There's some on TMD, there's some on sleep. There's other webinars on there, and some of the cases will be the same, but there was definitely some new cases today that you haven't seen before. So I went pretty fast. Might be something you might want to show your staff sometime. Might want to sit down at a lunch and learn and say to your staff, look, I'm thinking of getting into ortho. What do you guys think? And show the webinar to your staff and get their feedback. And if they're really enthusiastic, I would keep them. If they're not enthusiastic, I would fire them. No, I would. I mean, seriously, you will find out. Some people like new things and some people don't. And this is something big and this is something new. And if they were really enthusiastic, I would say, look, let's go do this together. Let's take the courses together. I think session 1 and 2, you can come for free. And just bring your staff to the course and see what they think. But this is something that will benefit you and your patients and your staff for many, many years. So again, thank you for your attention. We tried something new today. We did it early on. We usually do them at night. But again, it's something which I went pretty fast today. And if you need to watch it again, it's free. And again, contact Lee at rondaseminars.com and she can answer all your questions. And Tracy, again, thanks very much. Thanks for your help with my website. You make me a lot of money. I appreciate it. I can't treat if they don't come in the door, and you help get them in the door. So I appreciate that.
That's our goal. We appreciate the kind words. And as you mentioned, we did do an earlier time today. So when you take that survey at the end, if you have any comments of a time that's best for you, definitely put that in there so we can, better accommodate next time if that's the case. So, all right. Thank you, everyone. It's been great, and have an awesome afternoon.
Thank you, Officer. Thank you, Tracy. Bye-bye.
Bye.